We're going to start our session of panel discussions, and we've been collecting questions from you guys, those of you that have been submitting them electronically. And Brandon here has several of these questions and has others that he'll be posing to our esteemed panel. You've met two of the three already, although you haven't met Brandon. I'm going to let Brandon introduce the others, but I'll introduce Brandon Burkhead. So Brandon is a physician who's a technologist and deeply interested in the role of virtual reality. He's also the co-chair of what's called VR Core. It's the Virtual Reality Committee of Outcomes Research Experts. And he'll be talking to us later, so I can do a little pre-introduction now, about how do we improve the science of virtual reality. And he's going to talk about some new guidelines that have been suggested for new types of clinical trials for immersive technologies. So that will be occurring a little bit later. But now we're going to talk about, he's going to introduce these great panelists, and we can get in a little bit more detail and explore some of the fantastic, incredible talks that we've been hearing. So take it away, Brandon.
Definitely. Testing 1, 2. Oh, great. So I'm really honored to be able to moderate this panel of just fantastic individuals. I'm going to start from this way out. And so first I want to talk about Kate Donovan. So she has one of the coolest jobs in the world. It is Education Innovation Technology Coordinator for the Medicine Patient Services at Boston Children's Hospital. She essentially utilizes or creates technological solutions for global pediatric healthcare, and has a PhD from MIT on the complexities of integrating data from consumer healthcare applications, which is perfect for the job. I don't know if that's intentional. And then also, used to work for a small company called Apple. So that's Kate. And then Raphael, we've learned a lot about from his talk. Just fantastic energy. Futurist, innovator, speaker, has been done TEDx talks, and one of the first physician to use Google Glass in a surgery. So just fantastic innovations when it comes to surgical education and everything. And then Keith from yesterday. Keith is a man of many talents and many interests. He's kind of at the front line of primary care. Has developed a lot of programs of his own. He talked about a few of them yesterday, and so. Just a real diverse panel here. So I just want to introduce the topic. So we're a roundtable for medical virtualists. And so essentially we're going to be talking about kind of the ins and outs of actually implementing this into different settings and how that's been going as far as involving team members and kind of the nitty-gritty, if you will. So with that, I'd like to start off with a question. It's also a question about, maybe within your individual areas, so academic setting, community, and then outpatient primary care, your use of the technology, how has that been going? Were there things that you see as, solutions to some challenges in those areas? So I'll start with Kate.
We got to talk about challenges first.
You could do challenges first. Yeah, let's do it.
I think in pediatrics, there are a few challenges. We've been pretty successful getting the devices into the hospital, but actually getting it to the bedside has actually been our biggest challenge. And you have to think about that. Like, who owns this once it comes into the hospital? I definitely have run rogue in a lot of these things because I'm really interested in this space. But really, who does own this? We've talked about pain management, so does it go under the pain services? We've talked about distraction. Is it under the child life services? Does it go into the innovation? Does it go into simulation? So we really need to be very thoughtful about who actually drives this forward so we can do it very well. So I think that's for us definitely one of the things that we struggle with a little bit. Also, if you want to say a negative, and I know people have talked about this, is we still have to review the safety of VR. Remember, this is hijacking two of the major senses of the 5 sensors, which is sight and hearing. And that actually, there's been a study recently out of Leeds University that actually showed that kids stepping away from 20 minutes worth of virtual reality, it does affect them in their sight. Out of 20 patients that they did, 2 of them actually had issues with sight. So what are the outcomes of that? We really have to do a lot more in the research and get some evidence to back this up as well. So those are my 2 talking points there.
All right. Well, So I'm a full-time surgeon, as I said before, and I work at a hospital which is about 500 beds. It's a community hospital. It's a tertiary care center for 2/3 of the state of Maine. And it's a big healthcare system for Maine's size, I guess. And we are at the main hospital. And we're pretty innovative in many ways. But I tell you, the main, and following your path about challenges first, one of the main issues is really the engagement of the administrators. I think that it's so difficult to do anything, that I almost just quit trying there. It took me about 2.5 years to get them to try Augmetics, which is a virtual scribe using Google Glass. Well set, it comes from Palo Alto area. It's proven, it's FDA approved. It's all. And then for 2.5 years, I connected them. I put them in Skype call with the founders. I did the whole thing for them. And this is after I had told them. I met the founders of Augmetics in 2013 when they had the idea in their minds. And we could have been the first hospital in the world doing this. Now we are the 20th hospital. After 2.5 years, they finally said yes. So it's such a labor-intensive process to convince the administrators to engage. And people say, well, it's so difficult at the big hospitals, at Cedars-Sinai or UCLA. It's more difficult at a little sort of, relatively speaking, hospitals which want to be innovative, but they don't want to take any risks. So that's administrators, regulation. The regulation is evolving, for many things in digital health. From telemedicine to apps. I think the FDA, the people at the top of the FDA is becoming younger and more, proactive in the way of learning about digital health, and so it's easier to do it now than it was, 5-10 years ago. The other problem is the cost. Obviously, where do you get the money to? And everyone is thinking about money. The ROI, the return of investment. You got to have a vision, and you got to sacrifice, 3-5 years of, return for, being bold enough to engage in something that might really be changing completely, and you could be the first one doing it. So be a little bit bold, and like I said, sometimes asking for forgiveness rather than permission is good. And the other thing is education, which is why things like this, this conference, conference like this, it's our responsibility as clinicians or IT technology experts and people who are passionate about the potential of technology to really change how we do and how we teach medicine. It's really so important that we engage in telling sending the message, be like the pastor, like you got to shout it out so people really hear it, because it has to come from the patients up, Patients, they just want to be cured, quoting my good friend Denise Silver from Doctors 2.0, she once said, she said, patients want to be cured rather than secured. And, that is kind of true. Patients don't care if you have antennas in your head. They want to be healed, and if you can use whatever gadget to do it, go ahead and do it. So those are mine.
Yeah.
So speaking from the general practice or primary care perspective in the United Kingdom, the two things that come up, and everyone else is saying it, time and money. One of the principal problems that I've had with implementing VR, and at the moment in my practice it's almost exclusively being led by myself. I mean, I can make a very good case for using this, but the nursing staff are often requiring me to come through and help them. And I think that the way that the hardware and software works at the moment, it will always add some time to the procedure. It's not something you just immediately grab off the wall and away you go. And I'm sure it's the same in the States, but we work on very, very sort of tight time schedules. My average consultation time is a few minutes less than 10. Nurses isn't much longer than that either, and so the time to get a person in, explain how VR works, put it on, safely take them through it is tricky. So I think it's one of overcoming that barrier, I think, is to actually look and say, well, where are the areas where it can deliver the most benefit with the least impact in time? And I think what we heard earlier on from the Children's Hospital about phlebotomy clinics, blood sampling, and so on, I think that's the clear, easy space to go for. So first of all is time, and the second one is money. I mean, GPs in the UK, whilst I'm a salaried general practitioner, a large number of them are essentially self-employed. They're independent businessmen and they run practices, and the practices they run gives them a lot of flexibility over how they deliver care. So they've actually got quite an appetite for risk, but times are tight. And so I could go to them with, I often say that I could go to my fellow doctors and say, here, I've got a golden goose for you. It lays these wonderful golden eggs. And they'd be like, oh, thanks a lot. Where the hell am I going to store these eggs? You know, as if I haven't got enough to do, you know. So it's, but in the case of VR, it'll be a case of, well, I like the idea of it, but you know, is someone going to pay for this? And the NHS isn't currently paying for it. So yeah, time and money, but that's common wherever.
Yeah, thank you so much. This is actually, so I want to apologize. I do have my phone out, but it's not because I'm tweeting, though if you want to tweet that, feel free to. But I'm actually checking for questions that are coming up. And you're actually answering a lot of the questions that have already come up with logistics of, you know, who's going to do what, when, where. But then another really interesting question that came up was one of a question of, have you seen anything that relates to empathy for the providers and you know, each genre, and so I know I've only heard of a couple companies that are working on that. I think Embodied VR I saw out at Stanford. They had a VR conference, but you know, if you guys have heard anything for kind of empathy training or anything, you know.
I think I've heard what you've heard, actually.
Yeah,
Not much in that space. I know that it's something from a simulation perspective that they're exploring, however.
Yeah, there is, you know, Embodied VR, and there's another company, I can think of the name now and where this is. It's in the U.S., but I know they have the students, medical students, role play the patients, and so maybe you guys heard that. But so the best way, I think, to learn, I'm sorry, to learn to be a provider, a physician, is really to become a patient. You know, to face, you know, be in the other person's shoes. And I know this company was doing that with VR. And then there's another thing I read, you know, a few months ago, where they actually put a sort of a younger age person in an older person's body, add Alzheimer's or Parkinson's, and then they try to move. It's kind of a VR, also a suit-based type. So and the person really feels someone who's super morbid obese, and they put a person who's not morbidly obese on this sort of, and they can't really move, and they can feel it, and so the task of going 2 steps up to pick up, you know, so it's, but I can't remember specifics, so yeah, people doing it though.
Well, I can certainly mention some specifics I'd like to just now. I mean, the first one to say is that the Guardian newspaper, which I believe has a web presence here in the States as well, has been going quite big on virtual reality and 360, and they've actually started putting out some perspective experiences for teenagers with autistic spectrum disorder and the like. So it's out there at the moment. That's not technically clinical, it's not being prescribed. What it's doing is it's helping people get an understanding, or neurotypical people to have an understanding of what the autistic experience might be. And then the second thing, person that I want to reference is a gentleman called Nick Perez. And Nick Perez is working in Torbay Hospital in Exeter, which is in the southwest of England. And he's been working for quite some time now using 360 for the specific purpose of allowing healthcare professionals to understand patient perspective. And also human factors in training and so on. I've seen some of the work that he's done as well. And it's a simple concept. He's using readily available technology, but he's affecting some fairly significant changes, because I'll tell you something, as a doctor that's been a patient myself, you're absolutely right. The minute you see it from the other side, everything changes. And I wouldn't wish on everyone to become ill or be a patient to go through that. So if VR can help in that regard, I think that's a wonderful thing.
Yeah, no, that's awesome. That's awesome. We have another question. This one's quite interesting. When during the development of a prototype should an entrepreneur connect with, potential customers? I guess it's either the healthcare system, leadership providers and whatnot. Considering the importance of collaborative partnerships, have you heard much about that as far as feasibility of early engagement and any recommended approaches to entrepreneurs?
This is a hard one, actually. I know people struggle in the startup space just to get through the door, particularly a children's hospital, but really any hospital. I mean, they want to speak to the experts. They want to get the voice of the patients, the voice of the family. So how do we do that and allow that to happen? I think that definitely is a challenge for a lot of entrepreneurs. We have an accelerator, Boston Children's, that we invite people to come and pitch to subject matter experts, and a lot of times we are able to connect them with the right people able to move things forward. But I think just getting through the door for them is really difficult, but I also know the absolute importance of getting the voice from the patient right when you're starting.
Yeah, you know, I'm a full-time clinician and a geek of sorts, but I think accelerators are obviously, you know, an obvious answer. I wish we could give the mic to the public, because I know a lot of people in the public who have much more expertise in this topic. But you know, like the pastor was saying, you know, integrating, you know, all the players. I think it's so important to you know, if you want to do a health app and you're like a superstar tech person, you know, don't forget the patient, but don't forget the provider. You know, you gotta, you know, if you don't know what problem you're solving, and there's no best way to learn than to ask the guy who's suffering on the trenches, you know, day and night, and to ask the patient before you start engaging in spending time and money and sweat, you know, creating some platform. Once you have that plan, I think then, you know, go ahead and find the bugs.
Yeah, and I'd say to anyone who's got brilliant ideas that they want to prototype and take to a clinician is speak to a clinician, or preferably speak to a patient before you build anything at all. Because you may have what you think is a fantastic solution, but you have to have a clear understanding of the problem. And if you're dealing with healthcare, the most important person, let's face it, is the patient. And so you want to be able to speak to them. And how you speak to patients is then, you know, another matter. I found things, you know, actually personally, if you go onto social media, Twitter and the like, you can connect with patient groups very, very readily. So that's not a formalized way, but you can get a lot of feedback just there. It's the same with clinicians. You know, I'm happy to give feedback and advice to people who approach me through Twitter. It's at Keith Grimes, by the way. And in the United Kingdom, when it comes down to working more closely with getting access to clinicians and getting that information, there's a couple of programs, including the Clinical Entrepreneur Program run by Professor Tony Young, who was referenced, I think, by Brennan. He's a sort of great chief of innovation in NHS England, and he's helping to start break things down. And we have academic health and science networks, which are specifically there to take people who are looking to take a startup into healthcare to help bridge some gaps. So there's actually, I know I'm talking from a UK perspective, but there's hopefully something in there. I think, yeah, you take the UK bit out and just say, you know, think before you invest anything.
Yeah, no, that's a great point. And just to dovetail that for the U.S., there is some outlets. The AMA actually has an innovators portal that you can interact as an entrepreneur with physicians through that, at least for the U.S. But I have a question. This is actually specific to Kate. We talked about this. We actually tried to talk a little bit in an email beforehand, and you elucidated some of this. So the question was, what are the concerns specific for children, for pediatrics with VR, was the question. So.
Sure. So I think probably one of the first concerns really comes of the device itself, content. Content is definitely something. We are dealing with different age groups here, right? So we want to talk about building content specifically for certain age groups. Is it appropriate, developmentally appropriate content there? And then the devices themselves. The device I use actually has a stamp on it that says I can't use it for patients under 13 years old. I do, but I'm not supposed to according to that. And when, you know, someone puts a stamp on something, usually something has happened that indicates that we need to put a stamp on this. And this research has gone back for 20 years and some of the challenges here. But, you know, as I mentioned earlier, developmentally, we don't understand what the outcomes are going to be with this. So I think that's probably where I would go with that. But the content is definitely something we can work on. I mean, there's definitely workarounds with this. There can be some tweaks to some of the hardware. The hardware might be too heavy, it might be too cumbersome. So, you know, thinking from the lens of a child, the lens of a parent, when you're approaching parents from a pain management perspective, they're not always with open arms because their child is in pain, and I think we all can speak to that. If we have kids in our lives, you just want them to be pain-free. And if I'm offering VR over something that is a known, the other thing is VR is sold to people what they know of VR, I should say. It's a consumer product, and that's what they know. It's a consumer product. You know, little Billy's friend plays it with PlayStation and things like that. So now we're moving it into the healthcare space. We really have to have a lot of evidence to back this up. So I think from that perspective, it's really big. And if we talk about the tweetable phrase, as Oprah likes to say, it's our responsibility as clinicians to establish evidence base on the safety of this.
Yeah, no, that was great. The next question from the community of the crowd is, so in weight loss is another concern, is particularly in primary care. So I don't, this might be geared towards Keith as far as if you have seen anything for weight loss, or is that an issue that's kind of been circling around the VR community for you?
I mean, patients will present to me as a general practitioner for advice on weight loss, and the approach that we take is very much the approach that we've been asked to take for a lot of time, which is, exercise more, eat less, try and eat better. Identify those things in your life that might be contributing towards the difficulties in losing weight. But then when it comes to VR, I haven't personally used anything with virtual reality for patients in this area just yet, but having seen the talks earlier on today and seeing the hopefully very positive things from the SALT study we saw earlier on, which was specifically about making dietary choices, and you can imagine how that could be repurposed for different communities for different choices. So we have patients from India and Pakistan in the UK who have a higher rate of type 2 diabetes, and the interaction of their genetics and metabolism with a sort of a UK diet can often wreak havoc on them as well. So I could see that being really useful. And then I was really fascinated by the talk about embodiment, and we've talked about this too, I'd initially thought that it'd be really helpful to see what virtual reality would be able to offer patients with eating disorders. But now I'm beginning to think that there's a much larger population that if we could evidence some benefit from that, that would be amazing. If we could use VR to do that.
And then one for Raphael. Some of the audience was wondering, you talked about so many amazing different innovations going on. Which one do you think is most practical here and now, whether that's some of the educational ones or some of the other interventions that you talked about in your talk?
You mean specific? I mean, the question.
The question is kind of which one is, you have so much fantastic tech in your outstanding talk. Among all of that, what do you think is the most practical and immediate opportunity?
Wow. Well, thank you for the comment. I think at this point where we are, education is really anything education as a goal. It's already here, it's there. We should be able to tackle that pretty easily with multiple platforms that are out there already, and improve the way we train the next generation of providers or nurses or social workers or whatnot. I think that education is I think that VR and AR and mixed reality make a fantastic media now for doing that. Now when we talk about reading images or diagnosing or looking at x-rays, we're almost there, I think. When we talk about therapeutics, especially in surgery, it's really, or specifically in surgery, that's going to be difficult, and I think that we're a few years away from that. But in regards to education, training, simulation, we're there already, and we have some fantastic, people out there, with fantastic products, and I think the mix of virtual reality, the digital creation, the pairing of that with real anatomic data, with imaging studies, or MRIs, CTs, MRAs, or radiology studies, and the haptics, are going to make such a difference. And the haptics, it's so important, because I think that, there are great applications out there with controllers, with the HTC or Oculus, but when you put some real instrument in someone's hand and they feel real, and then you look at the instrument in VR, and it's like the amputated hand, and you see your hand in there, and you're actually having haptics on the hand, and you're learning to do a procedure, anything that is procedural based, again, for surgical stuff, for procedure-based learning, I think that we are there already, and it's going to be fantastic.
Yeah. So I just have one last question for our panel, and that is a great question of consent. So whenever you're using it, what type of process is that something regularly used? I know just from my experience with dental anxiety, that was we always had to get consent. But what's your? I guess
we also have to get consent. We're using the product somewhat offline, so we get consent and assent for the patients that we deal with. And again, the approach is similar to what we would do if we just go into a room or whatnot. just to be able to use that there. But we want people to know what, I feel like I'm such an advocate for VR, and I'm like talking about all the sad, negative things over here, and that's not like my intent, because honestly, I would put it in the hands of every patient I could. But again, these are challenges, and we do have to share that with the patients and the families. I mean, kids will pick up a device in a second, they'll just use it, and not a problem. But it's really the parents, and some of our parents at Children's actually are kids. So we have to, really just kind of circle back with the patients and the families so they have a true understanding of the experience themselves. And offering the appropriate content as well. We also use Applied VR because they have a lovely array of content. So that's my thoughts about that.
Yeah, absolutely. Anything with patients has to have informed consent, not just consent, very, they need to know what they're getting into, but most people, again, people don't care. If they have a problem and they just want to get it done. They want to get better.
Exactly.
So it's important.
And then from my point of view, yes, I do get written consent from every patient so far. It's part of the terms of how I'm indemnified to do this at the moment as well. I think, but from that point of view, when I think there is wider use of consumer VR tech in people's hands, then we can move towards a kind of implied consent, and the person comes in, and because the problem is essentially understanding what virtual reality is. I haven't had many patients so far who've already used VR, so I'm introducing them to VR, and so it's important to get this in writing. I think down the line, I think we'll move to the same way in the same way that I don't have to get written consent when I examine a person's chest. That they lift their top up at the back and let me listen as it. So I think that virtual reality might enter that down the line. But for now, no, I'm a careful boy. I'm getting it all written.
Well, thank you so much. This is great, fantastic. So yeah.
Thank you.